Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got a little bit of a different format for you. Way back in 2019, we recorded our gestational diabetes episode, and there's been some updates in the guidelines.
So the diagnostic criteria have changed, and some of the language around diabetes in pregnancy has changed. And so we're going to have a listen to that old episode and interrupt ourselves when we get to the point where where you really need to know the new numbers and the new way that we discuss diabetes in pregnancy.
All right, here we go. Well, welcome everyone. This is episode 17, and today we're going to talk about when you get told you have diabetes in pregnancy. It's really common, isn't it, Patty?
Look, it sure is, and sometimes it's a real surprise to people because they think I'm young, I'm healthy, I'm slim, and I eat well. So what am I doing with diabetes?
Yeah, and sometimes they think that they don't have any symptoms. So why are you even suggesting I should get tested?
Yeah, why is it even relevant?
Yeah.
Sure.
So for listeners, we are in the hometown of Ballarat, and it's beautiful here at the moment, isn't it? It's spring
Beautiful.
and
springtime.
And I'm going to channel my mum here, and she always thinks there's going to be more babies in springtime. Is that?
I love that's such a country thing that it's springtime and the lambs are being born, so there should be more babies born. When your mother says that, I just smile and nod.
In fact, there's no rhyme or reason, is there, for when our practice is busier than other times?
I don't think so.
No,
I don't think so.
We're not doing anything in January. That's a very busy month, isn't it?
Well, that's going to be the busiest of the year, isn't it?
Yeah. Yep. All right. So, Pat, is there a difference between diabetes and diabetes in pregnancy?
Well, yes. Most people are familiar with type 1 diabetes, which is the diabetes that comes on in children and young people and needs insulin injections. And type 2 diabetes, which is usually the diabetes that comes on in older people, usually associated with obesity. And pregnancy diabetes is different. It has something in common with those conditions, but the causes of it are complex. They relate certain degree to genetics and also to the behaviour of the placenta.
Okay. So
it's a different risk group. In fact, everybody's at risk.
Right. And so how common is it?
Well, it's up to about 12 to 14% of pregnancies. And certainly you're at high risk if you're very overweight or older, but you're also at some risk if you've got a normal body weight and you're young.
Yeah, right. Wow. All right. Well, why is it a problem in pregnancy? Why do we even test for it?
Look, the studies have shown that it's not great for the baby to grow in an environment of excess sugar. Everybody's heard of the idea that diabetic pregnancy, the baby can get very big and fat, which is true, and that can be a problem for the baby being unhealthy, but also maybe not fitting out. And then, but less people know about the idea that in diabetic pregnancy, the baby can be small and growth restricted and sick from being too small, and that's to do with the placenta not working terribly well if the blood sugars are highly abnormal.
What, it just becomes like calcified or something?
Yeah, so there's lots of complex ways in which the placenta can malfunction, and they're more common with diabetes.
Yeah, right. Okay. So when do we have the test? When's the most important time to be tested?
The standard test is done at 28 weeks, and sometimes that might be done earlier if someone had, for example, had gestational diabetes in a previous pregnancy or was very overweight or had some other risk factors. But the standard test for a healthy woman is done at 28 weeks.
Okay, Patty, just let's pause it there, because in the new guidelines, early pregnancy testing for diabetes, that's one of the changes in the guidelines, isn't it?
It is, but can I just say how young we sound in that old?
Do you reckon?
I think we do.
I think my elocution has got better.
bully for you. I think that yes. So that is a bit different. We used to just have the discretion to order an earlier test if we thought someone was at higher risk, and they have now clarified that a little bit to say that somebody at higher risk should have a different test at booking. When you have those first bloods, the hepatitis and HIV and the blood group and the rubella, you can have a different test, an ordinary blood test called a hemoglobin A1C that doesn't need the sugar drink, and it's a sort of a measure of longer term diabetic or longer term sugar control rather than just what you happen to have at that time on that day, which should be low because you fasted, and people who are over the limit on that test or have had a previous pregnancy diagnosed with gestational diabetes, then those people should have an early fasting 2-hour sugar drink oral glucose tolerance test much earlier than everybody else, between sort of 10 and 14 weeks.
I am glad that you've been able to decipher that, because I tried to read those guidelines.
They're hard.
And
it's hard.
they are the most densely written piece of medical information. I just think, well, what's the point? Like, just put it into plain English.
I think that we've got to work out where these guidelines are coming from. So the people in charge of this, it's quite a big committee of people from obstetrics and endocrinology and various diabetic authorities, and it represents a consensus statement about best practice in 2025. But they've certainly had an extremely close look at it, and when we get on to the guidelines of how to interpret the 28-week test, they've actually kind of relaxed the numbers a little bit. And probably slightly fewer people will be diagnosed with gestational diabetes. Some of the people who were just over will wind up just under.
Yeah. They've also brought up this new term, overt diabetes, or, a diagnosis of overt diabetes.
Yeah, so overt diabetes in pregnancy is worse numbers. And it represents a group who are probably slightly different. They've either got pre-existing type 2 diabetes that just never got diagnosed until they were tested because they were pregnant, and some people might have that, especially some people at really high body weights. And it means two things for that group. One is you're sort of way over the limit. So you're more likely to have more significant manifestations of your diabetes in pregnancy. It's more likely to change your obstetric management. It's more likely that you'll get complications like preeclampsia or fetal growth problems and interventions in labour and delivery. And also that person is actually much more likely to have either had pre-existing type 2 diabetes that nobody knew about, or still be diabetic when the 6 weeks after pregnancy is over.
Ah, yeah, right. Yep.
So they've brought that in as a sort of a new classification.
All right, Pat, I think we'll move on and see what else we said in 2019.
And that's that oral glucose tolerance test, which is the famous test where we go in fasted. And the blood's taken fasting, so straight up blood taken on an empty tummy, and then you drink the gross drink, which tastes like neat cordial.
Yeah, it's disgusting.
And then the bloods are taken at 1 and 2 hours after the drink. And The test is how well your body metabolises that sugar.
And the limits have changed a little bit, haven't they? So in 2013, they changed to be a little bit lower. So more women are diagnosed with diabetes now.
Yeah, so the Australian Diabetes Associations, the experts in the disease of diabetes, have changed a couple of times over my career. They've made some changes to make the diagnostic criteria more strict. So just a growth of knowledge in the area. It used to be thought that a certain level of sugar was not associated with problems. They found out it was. So to pass the test, you had to do a little better.
Yeah. And so I've got the limits here. So fasting, you have to be at or below 5.1.
Yeah, and that's it's clearly abnormal to have a fasting higher than that.
Yeah.
You haven't had anything to eat for 7 hours, so it should be low.
Yeah. And women do get a bit pent up about that. So, they say, well, I was 5.2 and they've said that I've got gestational diabetes and I don't believe it. And what do you think?
Look, I think there's probably the odd case where you could argue that it was a bit too strict, but we're going to have the cut off somewhere. A woman diagnosed as a borderline case has nothing to lose from that diagnosis. The diabetic diet is one we should probably all follow to a certain degree. So let's say you felt that you only failed the test because of the way that the test was conducted, or that you were having a bad day or something.
Or you had something to eat just before the time frame for the fasting started. And
the test has been designed in a way that shouldn't explain being over the limit. But even if it did, what have you really got to lose? We certainly have people who are way over the limit on the test, but they make some minor adjustments to their lifestyle in terms of diet and exercise, and they never get a single high sugar again for the rest of the pregnancy. Yeah. Well, it's not that they didn't have it, it's that those changes were necessary.
That actually had an impact, yeah, I know. I think you said the word that might explain it, and that is you failed the test. So
yeah, I should have said failed. Yeah, that's right. So this is what we worry about, isn't it? That people might feel an enormous amount of pressure. These oral glucose tolerance tests for diabetes, it's not a pass or fail test. It's how you perform on the test. And failure suggests that you've done something wrong. When you haven't, it's just sugar's too high and we're going to help you bring it down. Yeah,
or that your body's failed you in some way or whatever it might be. But that's kind of the language around it, isn't it, that women do feel like they've not passed that test.
Yeah, and I think that to have a little bit of understanding that the pathology behind gestational diabetes is complicated and it can be genes that aren't your fault and interactions between your system and your placenta that aren't your fault that can push the sugars up, and it's nothing to do with you eating the wrong – sometimes it's nothing to do with you eating the wrong things or not doing enough exercise.
Okay, so you made so many good points in that, Pat.
There were some good
points,
well done. Weren't there? Yeah.
2019, Patrick.
Congratulations.
So we talked about the fasting glucose level being above 5.1. Before we go into the episode too much more, let's just talk about the new limits for diagnosis.
So they've changed a little bit.
Yeah.
If we look at a standard a 28-week test, it used to be that it was gestational diabetes on the first number alone, the fasting number, if it was more than 5.1. And now a little bit more leeway, it came up to 5.3. And if it's more than 6.9, you're diagnosed with overt diabetes in pregnancy, not gestational diabetes. Mm-hmm. So that's that worse one.
Yeah.
Yeah. The 1 hour test, the old limit was 10, and now it's 10.6. And the 2 hour test, the old limit was 8.5. It's been relaxed slightly to more than 9. And if it's more than 11, it's overt diabetes.
How are people who are currently pregnant, who have been diagnosed with GD, but they might have been diagnosed at 5.2. What do they do now? Apart from being really annoyed at the system.
Yeah, they'll be annoyed. Yeah. So I think that they should carry on with the recommendation, and they should interpret their results based on the best practice at the time they had the test.
Mm-hmm.
Yeah. So I wouldn't be recommending people who are over the limit who were over the limit on the 4th of August but not over the limit on the 5th of August to change their management plan. But these are how we should interpret all results after that time.
Yeah. Okay. And this is where I see patients in our clinic that have had a diagnosis of, lower limit of blood sugar levels,
Yes.
and they've got their diagnosis of gestational diabetes. And because of this continuity of care that you get to do, like you just manage that person, and it doesn't seem to impact their pregnancy tons.
That's right. I think that no one likes to get this news, but it's a bit like the comment that I made back in 2019. If you're just over the limit, we don't rush out and start insulin or something. The first thing that we do is send you to a diabetes educator, get the diabetes educator to educate you on the disease and its management through diet and exercise, and then record 4 times a day sugars, fasting, 2 hours after brekkie, 2 hours after lunch, 2 hours after dinner, for a week before I do anything. And what you'll often see in someone who was just over the test, just over the limit on the test, old guidelines or new, doesn't matter, is that that's because they just drank a great big cup full of sugar. And on ordinary days when they're not, and they've had a little bit of a rev up from the diabetes educator to eat a bit better and exercise a bit more, suddenly on a day-to-day basis is fine.
This is hilarious because we'll listen to this in the app and you say nearly exactly the same thing.
Well, I think it's true.
Yeah. But the reason why I brought it up is I think for some people perhaps in a different system, in the public system, they go into the diabetes stream. And then it becomes quite protocolized from now.
Yes, and I think that is somewhat of a problem. The first thing you do is you get sent to a big thing called diabetes clinic and everything. And I think that we should be taking real interest and really precise care of any woman who's tested over the limit. But if that person in real world conditions consistently records 4 normal sugars a day, then they need to be watched closely. The amount of interfering that we'll do in the pregnancy of that woman is nothing like the interfering that we might do if that person comes back under real world conditions showing that the sugars are consistently and problematically too high.
And I wonder whether that's where this consensus came from, to sort of give a little bit of leeway in the limits, the cutoffs, because they've noticed this very thing.
I guess that might have been one of the things they were looking at. Certainly, it's a meaningful percentage of women in our community who are over the limit on the test, no matter how you look at it. Yeah.
Let's keep listening to us. Because it could be just your cultural background, couldn't it?
Yep. So some people are just sitting ducks. It's much more common to get pregnancy diabetes if you're from a Southeast Asian background, for example.
Yeah. And then does it make any impact if you've had other things like, you might have had gestational diabetes in the past or any other hormonal issues?
So women with polycystic ovaries, for example, are more likely to be diagnosed with pregnancy diabetes, and someone with a strong family history of type 2 diabetes is at higher risk as well.
Yeah. And I read somewhere that if you've given birth to a large baby, you're predisposed to it.
Yeah, maybe. And well, yes, you are. And the explanation might have been that you actually did have gestational diabetes back in that pregnancy as well.
Yeah, right.
Yep. And it just wasn't, for whatever reason, diagnosed. So, if someone has a very big baby with no other apparent explanation, we always think, hang on a minute, was this diabetes and we missed it?
And what is a big baby? Let's just go there.
Oh, well, I would consider a small woman with a small partner who had a baby over 4 kilos in the past and no diagnosis of gestational diabetes. I would think, well, hang on, maybe she did, and maybe we should have our extra sensors out for the same thing happening this time.
So there's leeway if you had a larger couple, both partners are bigger framed or whatever you would expect. If they had a bigger baby, then
that's less suspicious.
Yeah.
Yeah.
Yeah. All right. And the other thing is that if you've gained weight too fast in the first half of the pregnancy.
Yeah, that does happen to people.
Too many magnums.
Didn't you say you had a magnum?
Yeah. Too many magnums. That's my fault.
A magnum a day in the first pregnancy. Yeah, so a lot of weight gain, absolutely.
Yeah.
So in that regard, it is important. Body weight and diet are important, but they're not the whole story.
Yeah. All right. So I've come back and I've got a fasting that's over 5.1. What is mmol again?
Oh, that's millimoles. That's just a measurement of the amount of sugar.
Okay. And that's an Australian. That's what we use in Australia. But
yeah, everywhere will have their own system, but the Australian is you're over the limit on the test if it's more than 5.1 fasting, or more than 10 at 1 hour, or more than 8.5 at 2 hours.
All right. And we might put in the UK and the US standards as well in our show notes.
That's a good idea.
So, yeah, people can have a look at that. So in 2025, I'm sure that other countries might have changed their limits too. So we'll update our show notes to include the new levels in other countries as well. All right. So we're over the limit.
Sure.
What do we do now?
Yeah. So the first thing I like to say to people is don't panic. This is we can fix this. We can bring the sugars back down one way or the other. It's often easy to bring them back down, and when we bring them back down, the outcomes are good. So don't panic. The first thing I like to do is get the patients with gestational diabetes in to see a diabetes educator, because that's they go and spend half an hour with a diabetes educator and learn a bit about the disease, learn the basics of managing the dietary requirements. And you get a glucometer in the strips. Okay. So the glucometer is a little gadget that measures the blood sugar, and it makes a little prick in your finger, drop a little bead of blood, and the strip sucks the blood up off your finger and goes into the machine, tells you what the blood sugar is.
So this is something that you take home?
Yeah.
And do you know whether you have to buy it or is it cost?
Well, in Australia it's subsidised. Okay. So you go through a diabetes educator and they're the one who gets you all that gear.
Right.
And so they show you how to use it. And the first thing I want to see is a week's worth.
Yeah.
Okay. Because the test itself is a little artificial, isn't it? You don't actually drink that much sugar on a normal basis. No one sits down with a cordial bottle and just drinks out of the top.
Yes. Well, we hope not. Well, maybe one of our kids might, but
maybe.
Yeah.
So so you go to the diabetes educator and you get the gear and a book. And in the book they write the targets. So, we want the morning target to be whatever and the post-meal targets to be whatever. And you go off and you take your sugars every morning before brekkie and after brekkie, after lunch and after dinner. And we see people after a week. Oh, that's what I do. And sometimes they're perfect. And that's because the diabetes educator has also told that person about eating well and doing some more exercise.
Yeah.
And if they're perfect, they're perfect.
But they just have to keep eating well and exercising.
Yeah. You can't. Usually they're perfect because you've made some changes.
Yeah.
Yeah. So we carry on and we keep on measuring, because as the pregnancy progresses, the sugar metabolism changes a little bit and it can be harder to keep normal levels.
Is that why some women can control by diet and exercise, but then need a different treatment plan towards the end of their pregnancy?
Okay. Yeah. So your sugar's fine and then suddenly it's less fine and then suddenly it's not. Yeah. Okay. And then so we keep on testing, and at some point it might be clear that more treatment than just diet and exercise is needed. And there's two big treatments that are brought in after that. One is metformin, which is a tablet, and it's the tablet that people with type 2 diabetes traditionally take, and it's safe for use in pregnancy and works pretty well. Metformin upsets people's tummy and bowels.
Constipation or
diarrhea?
Oh, right.
And so it's not a hugely popular drug to be on, but after a couple of weeks, the upset of the bowels often settles down. And it's to avoid that upset of the bowels and also to try and be more precise that a lot of us use insulin.
Yeah.
Sounds a bit drastic. Why do you put me straight on insulin? But actually it's not that hard to do either. And in that setting, we go back to a diabetes educator and sometimes to a doctor who's an expert in managing diabetes.
What's their specialty called?
Well, they'll often be a physician, an endocrinologist.
Okay.
And they're specialist doctors who manage hard cases of diabetes for non-pregnant people, and they're also very good at managing it in pregnancy.
Yeah.
So they'll often help us with dosing and so forth.
So, Patty, in 2025, is that still the same sort of treatment for people in later term pregnancy that have uncontrollable blood sugar levels?
Yeah, that hasn't changed. So that's what's changed is the guidelines of how to interpret the test, but the management of somebody who's over the limit on the test is essentially the same.
Great. Let's go back.
And then what we just want to do is learn how to use the little insulin injector pen We put the cartridge in, dial up the dose we need, and it's got a little needle on the end.
A little fine gauge needle, isn't it?
Yeah, they're pretty small. You can't really get it wrong. You just pinch up some fat on your tummy or your thigh and put the needle in up to the hilt and push the button, having dialed up the dose on the pen.
Yeah, and as I know that there will be people that are a bit phobic about needles, but it's sort of a means to an end, isn't it?
Yeah, and even the most, even people who are scared of it at the start get the hang of it pretty fast.
Yeah.
And of course, insulin works like a charm, brings the sugars right back in line very quickly.
Yeah.
And the idea, of course, is that if you recreate normal blood sugar levels, the various processes of how the placenta works and how the baby grows should be restored to normal.
And so let's talk a little bit about that. I mean, we've talked about what the treatment is and what the levels are and stuff, but why do we care so much?
Yeah, it's an excellent question, and for a long time we didn't actually know that pregnancy diabetes was a significant condition. So some studies were eventually done that determined that outcomes were definitely better if we tested for it, saw it as a real thing and treated it. Okay, we've always known that pre-existing type 1 diabetes it really complicates pregnancy. So this is somebody who's already got diabetes, they're already on insulin, and then they get pregnant. We've always known that those pregnancies were complicated. But was gestational diabetes a real thing? The evidence that it is a real thing is not that old, but it's in now. And we know that it's a real thing, and that some of the complications related to diabetes in pregnancy will be seen with just gestational. It's not always mild, and we know that outcomes for mothers and babies are better if we treat it. And we know that immediate outcomes for the babies are better, are like how they go immediately after birth. But there's some fascinating research going on as well about whether the origins of adult disease can be dated back to the fetal environment.
Right.
So if you have a heart attack when you're 50 because your heart arteries are too hard and they get blocked, is there a tendency to getting hard and blocked? Can that be traced right back to what was going on when you were a fetus?
Well, in relation to gestational diabetes?
Potentially, yeah.
Yeah, right.
Yeah. So, this is still an area of research. But if we think that a lot of adult diseases are partially have their origins in the quality of the fetal environment, then it makes sense to maximise that environment as best we can.
Yeah. And so they're long-term potential complications of having gestational diabetes. What are some symptoms? I don't know what the symptoms of having gestational diabetes would be for the mother and the baby.
Well, the mother typically doesn't feel many symptoms, so it's a bit like type 2. Type 2 usually gets diagnosed because your GP thinks you're overweight and tests you for it, not because you come in with any particular complaint.
Oh, you're peeing a lot? Don't you pee a lot?
Yeah, you pee a lot. Yeah. No, but it's often just diagnosed through vigilance.
Yes, yeah.
And pregnancy diabetes is not. It's not that common for it to cause, that too thirsty, peeing a lot that could be related to, say, a teenager who's diagnosed with type 1. Much more often it just turns up on the test. Yeah. The reason why we have to test everybody, no matter how healthy, is it happens to healthy people, but also because it doesn't have reliable symptoms. Yeah. And then for the babies, well, we know that they can be sick because they're too small.
And that's because of the placental
dysfunction. Yep. They can be sick because they're too big. Okay, so a baby comes out 5 kilos, looks big and healthy, but actually sick.
And they're sick because of why?
Well, they have trouble maintaining their own blood sugars. When they've come out of such a sugary environment into the cold world where their sugar comes from what they eat.
Yeah.
So they look big and strong, but often their blood sugar will be too low. And in response to the sugary environment, they will pump out more of their own insulin and so forth. So these are all problems for those first few days. And if babies get too big, then getting too big to fit out is a problem. Yeah.
And so does that mean that most women with diabetes, gestational diabetes, will be induced?
Yeah, getting induced is common. And there's a few reasons behind that. One is that we'll often see complications related to diabetes happen at the very end. And if we can afford to get on with it before the very end comes, the very end of the pregnancy comes, then we can skip those.
What do you mean, like the baby? That's when the baby's as big as? Why? What are those things that happen at the end?
One of the things that commonly happens is that you can go from really nice control to really bad control after the due date.
So your blood sugar levels are spiking and all over the show,
and it can be smarter.
Variable.
Yeah, and if we think we can get away with an induction before all that happens, then that can be better avoided than treated. Yep. Secondly, if diabetes in pregnancy is going to affect placental function, that might not actually be revealed until the very end as well. So you can get past the serious problem of the placenta not working properly by having the baby before the placenta backs up. And sometimes we're trying to shave some growth off.
Yeah.
Okay, so big baby, macrosomic baby. Our best chance of getting that baby out vaginally might be intervening before it gets super big.
Yeah. And that's tricky, isn't it? Because people think, you read it again, that people say, oh, well, my obstetrician thought the baby was going to be 4 kilos or whatever, and it ended up being 2.8. No, that's probably an extreme. But
hopefully we wouldn't get quite that wrong. But that's a good point, right? So estimated fetal weight is a tricky thing. We try and pick big babies just by the old-fashioned laying on of hands. So we put our hands on the belly and we measure with tape measure.
Yeah.
Surprisingly accurate for a bit of old-fashioned analog technology, and the laying on of hands is surprisingly accurate in experienced hands. So I wouldn't say I'm any good at picking to the gram how big a baby is, but your hands do get pretty big if you see a pregnant woman in clinic and she's 34 weeks and you put your hands on, you go, this is way too big or way too small.
Yeah.
Yeah.
Pat, I think you meant when your hands get pretty good,
I think I might have to correct my 2019 self there. I meant your hands get good at picking a big baby, not big.
I think they stay the same size.
I think so.
So then you go to ultrasound. And ultrasound will give an estimated fetal weight where they'll measure the head, the belly and the legs, and computer model within the ultrasound machine will calculate an estimated weight of the baby. But it's an estimate.
Yeah. And say someone has seen someone and they've said with the laying on of hands and like it sounds like it's your natural practice to then go on for ultrasound. But if that isn't the natural practice of that particular health provider, can a woman then say, can I go and have a confirmation from an ultrasound, or is there any use in her doing that?
I would like to think that scans are being offered to people these days where decisions are being made based on the fact that the baby's too big.
Yeah.
Ultrasound, it's not 100% accurate in measuring the baby's size, but it's a lot better than nothing.
Yeah.
So I'm going to interrupt there again. I think that this is one thing that is being done a lot better across the board in Australia these days is the use of third trimester scans to expertly done, increasingly accurate third trimester scans to check on well-being of babies that we're concerned about in the last 4, 5, 6 weeks of pregnancy. That just seems to be an area that we're doing better at. And if we look at births that don't go according to plan, when we review some of those births, bad outcomes for women and babies, sometimes there is a problem where the baby that had a real problem was so-called hiding in plain sight. The woman had come to clinic so many times, nobody had picked up that the baby was way too big or way too small, and it was there to be found, but we didn't find it. Okay, and we're getting better at that bit. So it might be a little anecdotal, but I'm sure over the last 5 or 6 years, I've seen a significant change in the attitude to be very careful in the last 5 or 6 weeks of the pregnancy to make sure that a baby with a known risk factor, like gestational diabetes, is actually progressing in the way that you believe it to be from your clinical examination.
Now, you mentioned that a baby that is too big might have trouble controlling their own sugars. What do they do there, or what's does the baby go to the special care nursery or anything like that?
Yeah, so we'll usually bring the paediatricians to the birth of a baby where the pregnancy's been affected by diabetes, and there's a protocol within the hospital for managing that baby when they first come out. So babies that are over a certain size, or there's been diabetes, or both, are at risk of their sugars going way too low And the paediatricians will be onto that. They'll measure the sugar levels of the baby's blood with a little technique to get some blood that we use to test babies for all sorts of things. And if the sugars are too low, they'll treat that. And they'll use glucose jelly, which they can rub in the baby's mouth on the gums. And that works quite nicely in a mild to moderate case. They'll use an intravenous sugar drip in a severe case. And they'll often turn to early feeding as well. And that's we're talking about before the breast milk comes in. So give formula from the start until the breast milk comes, because the baby's sugar's too low to wait for the breast milk.
And I also read that, again, motivated patients with gestational diabetes might actually collect colostrum before.
Yeah, absolutely. So that works really very well.
Can I tell you, they must be very motivated. I remember trying to get some colostrum, and it's like droppers, like a drip. Yeah,
you need a little 5 ml or 1 ml syringe and just pick it up in little beads off the nipple, and it's hard. But people can. So you collect it in a little syringe and squirt it into a little urine specimen container, and then freeze it. Yeah.
So I want to interrupt here because back in 2019, antenatal expression wasn't that common.
Yeah, it was really for the enthusiast. Who thought that the last thing in the world they'd want to do is use a formula in the first couple of days. They'd much rather have some of their own, and that's changed.
Yeah,
a bit like when dyed cord clamping came in. It was for the enthusiast to start with and quickly became standard practice.
Yeah.
And same with antenatal colostrum expression. That's become really normalised and mainstream.
Yeah. So in our clinic, our midwife, lactation consultant, actually sees people in the prenatal phase and helps them learn how to do antenatal expression if they're having trouble.
Yeah.
And also explains to them, if you only are getting drops, then that's okay.
Yeah, you don't need much. So a couple of mils in the bottom of the urine jar is actually quite a lot for a new baby.
Yeah. Yeah. So that's a change since 2019 for sure. So when can you start that?
Well, some people start to lactate from about halfway through the pregnancy. It's seen as a bit of a nuisance, but if you collect it, it's unbelievably handy to have it if there's a problem with delayed onset of lactation or if the baby comes too early.
Right. And can't suck.
Yeah.
Yeah, so that's back in the Premi episode. Yeah.
Yeah, so the peds will put the nasogastric tube down and then they can put the express breast milk down the tube.
Yeah. Oh, clever people. All right, so if I've got gestational diabetes, what does that mean for my personal long-term health?
Yeah, it certainly raises your risk of getting type 2 diabetes in the future. And that's just they share some common genetics. So everybody who's been diagnosed with gestational diabetes should have another oral glucose tolerance test at 6 weeks after the baby comes. And that's to make sure that they don't have type 2 already. So especially somebody who's overweight, what we might be finding at their 28-week diabetes test is just type 2 that they've had for ages. And they've still got it even after the pregnancy hormones have gone away. So some of those will be positive, and that's type 2, and that person should be managed accordingly, and weight reduction, lifestyle change, and tablets. And most people will pass that, but in the future, they are more likely to get type 2 than somebody else. So they would keep in touch with their GP over the years and get tested from time to time.
Yeah, and just instigate a diabetes diet for that whole time. It's probably, as you said, we all should be eating.
Yeah, so that person, well advised, would be trying to stay in better nick than they otherwise would have, because they're at higher risk of diabetes.
Oh, one question I meant to ask, if someone's in a really long labour and they've got gestational diabetes, what is their blood sugar level doing?
With gestational diabetes, it's usually fine. You don't go too low with gestational. So if anything, it would be a little bit high during the labour, and that's not the end of the world. If you've got type 1 diabetes, taking insulin, then it's always a balance between the food you put in that pushes your blood sugar up and the insulin you inject that pushes your blood sugar back down. And in labour, in active labour, people don't eat much.
And also they're expending energy.
Yeah, so you're spending energy, you're not eating much, and it's easy for your blood sugar to go too low. So it's like running a marathon. You don't stop to eat. You might stop to drink Yeah. But in advanced labour, it's the same as the marathon. The cardiac output, all the blood from your heart, is going out to your muscles, and in the labour, it's going into the uterus. Not much is going to the gut, and the gut knows that. So you don't want to eat, so because not a lot of blood supply going to the stomach and the small bowel. So your system knows that you shouldn't eat. So you don't need usually as much insulin as you think, and that's why in labour with a type 1 diabetic we'd use a sliding scale. That's just a way of dosing the insulin based on what the blood sugar says.
It doesn't matter even if you've got gestational diabetes and you've been using insulin to control it.
Mm-hmm.
That's
gestational with insulin, yeah, you might use a sliding scale as well.
Yeah.
Yep, gestational without insulin, no.
Yeah, and we've probably gone into sort of obstetric consultant territory and you don't, listener, need to sort of concern yourself about that. The obstetrician or your healthcare provider in charge will be the one sort of controlling your
Yeah,
blood
I think
sugars.
all we need to know about sliding scales is that it's a way of adjusting the dose based on what the blood sugar is right now.
Yeah.
So you might take a blood sugar level every hour or two and take a dose of insulin to match the sugar, the immediate sugar.
Yeah.
Yeah.
I'm going to interrupt myself here. I found that what I said was a little bit condescending, and I think that has changed since 2019, where I said, the complex stuff, you just leave it to your obstetrician consultant because...
Good point. That's actually turned out to be really one of the reasons why we do this podcast, and that is that the technical detail is of interest to pregnant people. And the feedback that we get is that we do a good job of not dumbing it down, and that we probably engage with people at a higher level of technical complexity than some other resources, and people like it.
People like it. So, yes, I'm so sorry if anyone listened to that and said, I will get that information if I want to. Thank you very much. Sorry, I didn't mean to.
2019 was don't worry your pretty little head about it.
Yeah, no.
And now we're saying, actually, you can worry as much as you like, and here's the information, and it's not, a lot of it's not rocket science. This is information that is available to non-experts for their consideration.
Yeah, and I think it's about agency. It's about not feeling like you're done to. You're actually in the team that's making these decisions, and you're at the centre and the heart of that.
And if this is happening to you and you have a working knowledge of how it all works, you'll feel and be empowered.
Yep.
And then after the baby's out, or more accurately after the placenta's out, gestational diabetes goes away. Immediately, yeah. So
that is phenomenal, isn't it?
Well, it is, but it just goes to show how much of it is about
hormonal.
the placenta. Yeah. It really goes away immediately, and so convincingly that we don't even really bother checking the sugars from that time onwards.
Yeah, wow. Apart from your 6-week check, just to make sure you haven't got type 2.
Exactly.
Yeah.
So the baby gets checked. They're not that good at telling us stuff without us checking, but even if it's insulin dependent, it'll go away straight away.
Yeah, right.
Yeah. People with type 1 have still got type 1.
Type 1, that's their lot in life, and they got that at birth, or not birth, but early onset.
Yeah. Well, they might have been set up for it as a fetus. Who knows?
Yeah, who knows?
Yeah.
Well, it'll be interesting to get that study. Well, when it's finally released about.
There's lots of studies. It's an area of study where they're just looking at how many diseases have their origins in fetal life, and presumably as a corollary, what can we do about that? Yeah.
Yep. Well, fascinating. So I just wanted to recap. Firstly, they're about 12 to 14% of all pregnancies, people have gestational diabetes, which is quite high.
Yep, got to test everybody.
Everybody gets tested, and it's a oral glucose tolerance test at 28 weeks. 28 weeks. And you have increased risk of gestational diabetes if you've got a history of type 2 diabetes in your family.
Mm-hmm. Overweight. Polycystic ovaries.
Over 40.
Previous pregnancy affected by gestational diabetes.
Yeah. Your healthcare provider will send you off to a diabetic educator, and you'll be sorted from there.
They're the most valuable resource. It's all about education. Most people who know someone with type 1 diabetes, they're a whiz at managing their own sugar levels.
Yeah.
They become better at it than their doctors by a mile because they know their own system. And I like women with gestational diabetes to be highly educated about what it is.
Yeah.
And a good diabetes educator will get people up to speed in no time, taking it seriously, getting those sugars as good as we possibly can. Yeah.
Now, let's just add in the new 2025 without going into the levels and stuff, but, terms that people might hear is a diagnosis of overt diabetes.
That's the big numbers.
Yep, big numbers.
That there's gestational diabetes for which the thresholds have slightly changed. And there's the use of booking blood hemoglobin A1Cs.
Yeah, in early pregnancy, in your first pregnancy screening tests.
Mm-hmm.
Yep, great. And the reason why we do all of this is because it can impact the growth of your baby. Either they'll be growth restricted or your baby will be too big.
Potentially too big. Yeah. And then problems with labour and delivery and problems in the neonatal period that are all better prevented than treated.
Yeah. All right. And so my big takeaway too, Pat, is just to tell people that it's not a failure. This is not a failure. This is just, it's so common. It's a common symptom of, well, not symptom, a common issue in pregnancy.
Yeah, to do with complicated interactions between the placenta, the fetus and the mother, and not a matter of necessarily being overweight or having a poor diet or not exercising enough.
Well, Pat, I've really enjoyed listening to 2019 Pat and Brigid.
I think we're doing a pretty good job.
Yeah, I think that was a really great episode, and someone that has just been diagnosed with gestational diabetes, I hope will feel a lot more kind of at peace with that diagnosis after listening to that.
Yeah, I hope so, and that it's not a matter of personal failing. That it is a well-established complication of pregnancy that we're on top of the management of, and that the recent changes that have been made are sort of tweaks to the system, but otherwise not a revolution in the management of pregnancy diabetes.
Great. All right, everyone. Thank you so much for listening and tuning in to this episode. It's a condition that affects so many people, so I hope a lot of people pick up this episode and have a listen. If you like our content, we would really love it if you could share it with a friend and give us a 5-star review on one of the apps that you're listening to us on. And drop into our DMs, which is at the Kick Pregnancy Podcast. Until next week, thanks very much and bye for now.
Thanks for listening, everybody.
Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.